Okay, I'm back. New bangle, new bling. We're going to go through the entire whistle stop tour of Gynae emergencies. A big reminder that they're all going to need some form of resuscitation at the top there. Okay, so on history, these two patients may or may not have had a history of amenorrhea. They may or may not know that they are pregnant. They will definitely have been sexually active. They may or may not have been on contraception. Okay, contraception does fail. This patient will definitely have been sexually active and may be using condoms, may not be. If they are, doesn't mean PID is off the table. This patient may or may not be sexually active. So if you have someone who has never had intercourse, who's got severe unilateral pain in the abdomen, an ovarian torsion is right up there in terms of differentials. Okay, symptoms, what a patient's going to tell you. So retained products of conception, there's going to have been significant PV bleeding, may have seen products. There's going to be cramping lower abdominal pain. Okay, it's a labor type pain. If this is a septic miscarriage or a backstreet abortion picture, there may be a discharge with worse and more persistent pain, rigors, and fevers. Your ectopic patient is going to have hardly any bleeding as contrasted to the heavy bleeding over here. Severe acute unilateral pain. When that ectopic ruptures, the pain is sudden in onset and severe and localized to one side. Nausea and vomiting because acute abdomen, shoulder tip pain because peritoneal irritation. PID, you're going to have severe unilateral or bilateral iliac fossa pain with or without a vaginal discharge. It doesn't always happen and may have nausea and vomiting cause acute abdomen. This ovarian torsion patient is going to have that severe acute unilateral pain, sudden onset. It may come and go if it's torting and untorting, may also have nausea and vomiting. Now you see them sitting on a bench in casualty. They're probably not sitting on a bench in casualty, especially these three. They're probably hunched over on a stretcher. If this patient is septic, she's going to be very sick. If not septic, she might look stable if she hasn't bled a lot yet, or if she's extremely hypervolemic, she might be very sick. This patient is sick if she's ruptured. This patient is sick, and this patient is sick. Vitals. So if this is a septic miscarriage or abortion, the pulse rate will be up, the temperature will be up, and the BP will be down. So we are looking at septic shock happening here, potentially. If not septic, she may be stable if it's still the early stages, or else if she's lost a lot of blood, her pulse rate will be up and her BP will be down. In the ectopic, same story, blood loss equals raised pulse and decreased blood pressure, especially if ruptured. Here we have a raised pulse rate with a raised temperature and probably a decreased BP, especially if you're in grade 4, which is septic shock. This patient is going to have a raised pulse rate because of pain and a raised BP because of pain. So they're all going to have a raised pulse rate. These two might have a fever. And these three are likely to have a low BP. This one is likely to have a higher BP. On general examination, what is there to see in each of these cases? This patient's probably pale, this patient's probably pale, probably nothing much to see in these cases. Okay, so now it's going to get awkward because I have to move the camera down so that you can see the rest of the situation. Side room tests and management. Okay, I just want to make sure that this is straight so that you don't have to scrunch your neck. And the tripod is doing something funny now. Okay. Resource constrained teaching in the time of COVID. Okay. Moving on now to the abdominal examination. If this woman is septic, she's going to have marked suprapubic tenderness with a subinvoluted uterus. If she's not septic, she might have a bit of uterine tenderness, but remember, in a non-septic miscarriage, the pain that is experienced is because of labor cramps. If it's septic, the pain that is experienced is because of inflammation and infection. Okay, so it's going to be these two characters are different things altogether. So not septic, moderate suprapubic tenderness possibly, and the uterus will usually be palpable because it's subinvoluted. This patient is going to have severe unilateral iliac fossa tenderness with rebound and guarding, so symptoms of peritonism. This patient also severe unilateral or bilateral iliac fossa tenderness, also with features of peritonism. And this patient is going to have severe unilateral iliac fossa tenderness, usually not with features of peritonism, but if it's really, really badly infarcted, then you can. Vulval examination. You may see blood, either dried blood or fresh blood coming through the vaginal introitus. This vulva is going to be normal. This vulva, you may see a discharge coming out of the vagina, but it's usually normal. And this vulva is going to be normal. On speculum examination, you are going to see blood in this patient with retained products, and you're possibly going to see the products themselves. If you do see products in the os, you take a sponge holding forceps and you gently remove them. This, putting a speculum into these 3 patients is going to be excruciating. It's going to be sore for this woman if she's septic. This woman, it's going to be extremely tender. The cervix will appear normal. This woman, it's going to be extremely tender. The cervix will appear normal. You might see a discharge coming from the os. This is going to be tender and the cervix is going to appear normal. So all of them, the actual cervix is going to appear normal. This one, you might see some stuff sitting in the os. If not, it means the products are just still sitting in the uterus. Bimanual examination. If this retained products patient is septic, it's going to be incredibly tender, bulky uterus, but it's not going to be adnexal tenderness and no adnexal masses. If not septic, she might be a little bit tender, probably not, definitely not as much as if she's septic. Bulky and enlarged uterus. Os is open. That's a very important way to differentiate these 3 things. The ectopic is going to be very tender on bimanual, normal size uterus with severe cervical excitation tenderness, because when you ballot the cervix, you're moving the ligaments that are attached to the tubes, and the pathology is in the tubes. You're going to have severe unilateral adnexal pain, and you're probably not going to feel an adnexal mass because ectopics rupture very early on in pregnancy, so you're probably not going to be able to feel anything. And importantly, the os here is closed. PID, very tender again, normal sized uterus, but severe CET because you're agitating the tubes, which is where the infection is. Severe unilateral or bilateral adnexal tenderness, and you may be able to feel the tubo-ovarian complex adnexal mass, depending on your level of skill and how big it is, etc. Os is closed. Torsion, also tender, normal size uterus, not really cervical excitation tenderness. Severe unilateral tenderness, and you are likely to feel an enlargement on that ovary of some kind. Os is closed. So the comparison, this patient's os is open, these oses are all closed. Side room tests. The HB in the 2 bleeding women is obviously likely to be low. The pregnancy test in the 2 pregnant women is going to be positive. The urine dipsticks in the pregnant woman is likely to be normal. Moving on to your PID case, HB, bedside HB is probably going to be normal, pregnancy negative because pregnant women cannot get PID. The urine dipsticks can be clear, or there can be protein and leukocytosis from a discharge. Torsion, the HB is normal, pregnancy test is negative, and the urine dipsticks will be clear. Then we're jumping straight into management before we go on to investigations, because with all of this information and the comparisons that you can hopefully now make between the 2, you can make a decision on management before you get results of special investigations, or if you can't get the special investigations. So your retained products needs a manual vacuum aspiration, may or may not need antibiotics as well. If she's septic, obviously she will. Ectopic, laparotomy. There are some ectopics that you can manage more conservatively, but hell, you are not equipped to make that decision. So if you think someone has an ectopic, they've got to go somewhere where there's a theatre and people who are better equipped to make that decision. PID, definitely triple antibiotics, but followed by oral antibiotics. Okay, the triple antibiotics don't cover all the organisms, the secondary invaders that are involved. And this patient is most likely to need surgery as well. And your patient with a torted ovary is going to need a laparotomy, at which point they will untort the ovary, see what they can do with it, remove whatever mass or cyst caused the problem. Okay, so now we have to move down one last level, and there's a big, is that straight? That seems straight. There's a big piece of ridiculously pink tinsel here to remind you that there's a bottom line. And the bottom line is that you can manage these conditions without having access to all of this information, just with your clinical judgment. If you are able to do the special investigations, then scan for sure. You're going to see retained products in the scan. You're going to see an empty uterus, well, a uterus that is empty of a fetus in the scan, and you're going to see a little adnexal mass there. If it has ruptured, you will see free fluid, which is blood, in the pouch of Douglas, so in the pelvis. This scan is going to show the tubo-ovarian complex, and this scan is going to show an adnexal mass. If you are able to do blood flow studies, it's going to show a decrease of blood flow to that area. If this patient is septic, so the two people who are septic, this one potentially, this one definitely, they are going to need an FBC to look at the white cell count. These two who are bleeding are going to need an FBC to look at the hemoglobin levels, okay, because they're bleeding. And these two bleeding women are probably going to need a cross match as well. The septic patients are going to need a blood culture to make sure that the antibiotics are treating the infection. And that is it. Remember, you can get all the way here and manage here already. This is just like extra. Okay, we are in a resource constrained environment. You need to use your brain to make a decision. And your brain is a much more powerful tool than like literally any of the stuff. Okay, that's the end of Gynae Emergencies.